Yeah, I think what we'll do is get started, and then those people that can join, I think because the meeting is being recorded, people can pick up anything that they've missed at the beginning. But first of all, thank you everybody for registering and coming along at this time at the end of the day. Today is the first in a series of webinars that CFSD are recording, which are designed to showcase some of the pathways that were published and collaborate with the wider clinical community, and giving a forum where there's the ability for people to get some education, some informal discussion, and ask questions and answers at the end. So tonight, as I said before, we're obviously going to record this and we'll upload it onto the CFSD's website as well, so just so that everyone is aware of that. So tonight we're joined by Matthew Barber, who's a consultant breast surgeon in NHS Lothian and the clinical lead of the breast SDG. He's going to talk about the symptomatic breast pathways and breast referrals in general. And then following Matthew, we've got Anne Wales, who's going to talk about the Right Decision Support Platform and the resources and give us some more information about that. So in terms of questions for Matthew, Matthew will kick off and start giving his slides in a couple of minutes. But if you've got any questions, there'll be a question and answer session for at least 10 minutes at the end of the talk. But if there's anything pressing during the time Matthew's speaking, then feel free to put your hands up and we can pick a moment to do that. So Matthew, you have done a huge amount of work in breast in terms of looking at breast pathways, not just for breast pain and breast lumps, but also for the wider range of other symptoms that come through the breast community. It's been fantastic to see what the effect of that has been by not needing to see so many patients with breast pain, for example. In our symptomatic breast clinics, we've been able to reduce the waiting times for those people who have breast lumps and are much more likely to have cancer, and that's made a huge difference to access across the country to the breast services, which are under significant challenge. So I'm going to hand over to you, Matthew, if that is okay, in terms of starting your slides. Can you take over the control from there? Perfect.
Yeah, yeah. So hi, my name's Matthew Barber. I'm a consultant breast surgeon in Lothian. I'm also the clinical lead for the symptomatic breast group for the CFSD. So these were set up a couple of years ago under the auspices of CFSD and NHS Scotland. And the idea was that it was to try and reduce the variation that there was around the country for patients and for the in terms of the service that they got, and in part also to improve efficiency as well. And to that end, we've developed a number of pathways over the last couple of years. The auxiliary one it just went live about 2 days ago. The breast pain one was very early on, a couple of years ago. So the guidance is in the form really of bullet points that they've got a little video link attached to them where we run through the main points. We haven't done the auxiliary one yet. We'll do that. That will be up soon, hopefully. And we've also, in parallel with these, tried to write corresponding patient information on NHS Inform, and the guidance and is really based on the existing cancer referral guidance, which is up for revision, and I'll refer to some of the revisions as well. This guidance is up on the Right Decision Service website, which you'll hear about in due course. So it's all there and hopefully fairly straightforward. Some of it, or a lot of it, aimed at primary care, but some at secondary care as well. Today, I'm going to concentrate on the sort of primary care aspects of breast referral. So the issue that comes into primary care, you have a patient who presents with an issue, and that patient wants assessment and ideally reassurance, or if there's a problem, for that to be dealt with. And if that can't be provided in primary care, it needs to be provided by somebody who can. But at the same time, breast clinics have finite capacity, and there are many issues that don't actually require a breast clinic. And the issue that you have and that patients have is that the driving this the concern are conventional media, social media, charities pushing the patients, and also GP confidence and ANP confidence in primary care, and we know that the amount of training that you get in breast is not huge because you've got lots of other things to deal with. There's hopefully some things we can do to help that. So I think in most units around the country, we're delighted to have GPs come and visit and sit in with us, although we know there are practical issues with that. There's online teaching like this out there. There are books on the subject. There's a question of, is it worth having a specialist in each practice who deals with a particular topic? But again, we know folk go on holiday, and we know that those specialists may not actually get much extra training. They just get lots of that topic for them to deal with. And hopefully the national guidance we've provided provides a bit of background and also support as well for primary care. And this is the balance we're trying to strike. So if you send us every patient with a breast issue, you'll want you won't miss any cancers, but the patients will wait, and there are big variations around the country in how long patients wait to be seen, and some areas do pretty well, and some struggle, and partly that's on the basis of staffing, and partly on the recovery still from COVID type issues. And this is what's happened over about a 4-year period from 2019 to the end of 2023. So you can see, so that's Christmas, and that's COVID. But you can see that there's a kind of inexorable march upwards of these figures. Now, at that time, it was 65%. The most recent figures, which we're not allowed to present because they're provisional, it's 75%. So over that time, there has been this is the number of urgent suspicion of cancer referrals marching inexorably upwards. We've been trying to pick out, because we know this is not all the referrals, that there are urgent and routine referrals as well. Now, NHS Scotland doesn't collect them, but because there isn't a target related to them. So, but we've tried to look at that, and there are differences between regions. So if you're in a region where patients wait longer, there tends to be a higher proportion of urgent suspicion of cancer referrals. But the pattern of increase is not dissimilar. And then correspondingly, what's happened to the number of breast cancers we've diagnosed? So this is the number of new breast cancers over the last 15 years in my region in southeast Scotland, and there have been wobbles up and down, but despite the fact that we've got an aging population, we've got an increasing population, with folk having babies later and less breastfeeding. Actually the number of breast cancers has remained pretty static over that time. So this is the total across the region with the numbers in the various hospitals, and about 400 to 500 of the cancers that are diagnosed in the region actually come from screening. So thinking about referrals when you're sending patients to us, first of all, we want to know the complaint. What is the patient coming to you about? And then we want the relevant patient details to us. So things like the past history, what drugs they're on, and that's really the basics that we need to know. Beyond that, there are a few issues that we may or may not need to know about. So, have they got a family history? You know, actually, a family history doesn't help you decide what's wrong with the patient in front of you. We're going to ask it anyway. Patients are often described in referrals as having a strong family history, where technically it's not. It is a family history, but it's not a strong family history, and these things do have implications. Examination. So ideally, it would be nice to know what you think, but beware. We have a steady trickle of patients where the patient turns up with an issue, is examined, the examiner feels they've got a lump, and then that sort of opens up a different investigation pathway for us. So beware. If most patients who are reasonably with it are going to find a lump in their breast well before you do. So unless they are actively concealing it. So be aware of describing lumps if the patient hasn't found one. Antibiotics, we get quite a lot of referrals of patients where they've attended with a lump, they've been given some antibiotics, and the lump's still there. So the question was, why were they given the antibiotics in the first place? Did they need antibiotics? The answer to that question is probably no, unless they've got an abscess. But if they've got an abscess, we probably need to see them anyway. If they've got cellulitis, that may settle quite quickly. We may not need to see them, but I think there is a question of do patients need antibiotics, particularly if they've got a lump. And then urgency. So there are some units, so our unit and Forth Valley, we largely ignore what you tell us in the way of urgency, because we know that a proportion of cancers are referred routinely, and we don't want them to suffer from that point of view. And that's not because you've necessarily referred them wrongly. It's just because we pick up incidental things and so on. So, but again, because of the finite capacity. So, for example, if it's recommended that a patient's got a lump and they're over 30, they're referred urgently. Now, if you've got somebody who's 22, you're quite entitled to refer them urgently with a suspicion of cancer, but they're very unlikely to have a cancer. So just bear that in mind because of the sort of capacity issue that we have. The other thing to bear in mind is that patients will sometimes find a lump from pinching the breast. So and breasts feel very funny if you pinch them, and so we would advise examining with the flat of the hand, and that usually will find you a real lump rather than a pinch lump. The other thing that we get in referrals is that you wonder whether the patient's got a cyst. Now, cysts, as you know, can occur all over the body, and in the breast region, they're either breast cysts, which are common, particularly in women in their mid to late 40s, and there are skin cysts. And these are very different, obviously. And if you think it's a breast cyst or you think it's a skin cyst, please tell us that, because that again is useful for us to know. Don't promise patients are going to get particular tests. So the part of our guidance now is that patients with breast pain alone don't need any imaging. But if they've been promised they're going to get an ultrasound scan when they go to the clinic, it's sometimes quite difficult to unpick that. So don't promise particular tests. If the lesion, a lump has gone, then and the patient's back to normal, then we don't need to see the patient. The Forth Valley is trialing at the moment an open access system, so patients with lumps who go to their GP, the GP practice will organise a a secondary care clinic appointment without them having to see anybody in primary care, and other units are looking on at how this goes with interest. In terms of the symptoms that patients have, we haven't produced any guidance on lumps, but if a patient's got a lump, we want to see them. However, the majority of lumps that the patients present with will be benign, and that the sort of lumps that patients get vary widely, largely depending on the age that the patient is. So patients in their teens and 20s tend to present with fibroadenomas. Patients in their mid to late 40s tend to present with cysts, and patients as they get older, the likelihood of cancer increases. But a lot of patients have benign issues. A few other things, the sort of common causes of lumps that we see, although probably less commonly in primary care, will be fat necrosis, lipomas, phylloides, and hamartomas. But if a patient's got a lump, we probably need to see them. They'll get triple assessment. We'll get to the bottom of it and manage it accordingly. In terms of other common symptoms, breast pain is the first one we'll talk about. So there are two main sources of breast pain. One is sensitivity in the breast tissue related to cyclical hormonal changes. And the second is actually coming from wear and tear in the underlying chest wall muscles. Neither of them are due to an actual issue in the breast. They're either a normal hormonal change, or they're a wear and tear issue in the chest wall. A few of them will have cancer, but these cancers are incidental, and that rate is about 0.4 per 100, which is about half of the rate in breast screening. So because of that, we don't recommend routine breast screening, but we do encourage people to attend for breast screening if they're of an appropriate age. When you're seeing somebody with pain, there are a few relevant issues to think about in the history. So the first is age, or more specifically, their menopausal status. So if they're postmenopausal and not on HRT, then they don't have cyclical or hormonal change, and it's very likely that they have got pain arising from the chest wall. And then you're interested in, is it related to the cycle? Is it related to activity? And factors such as what work the patients do. Are they a carer? Are they a nurse? What dependents do they have? Are they using a stick or a walking frame? Have they just joined a gym? Have they got new grandchildren that they're playing with? Have they got a new dog that's dragging them around for walks? Have they got shoulder or neck or back problems that might be contributing to wear and tear in those chest wall muscles? The pain, although it may be described in the breast or the chest, people often describe it moving to their armpit, and that's not because they've got a cancer with armpit lymph nodes involved. It's because the pectoral muscles on your chest wall go up to your armpit, so often you feel the pain heading that way. People often describe pains going down towards their nipple, and that's because the nerves, as they pass through the chest wall, and then lots of them will head down towards the nipple. So that's where we feel the pain. If you're examining a patient, first of all, have they got any palpable abnormalities? So if the patient's got a lump, then we need to see them because to assess the lump. But as I say, patients will often find an abnormality before you do examining you. And then the question is, well, what is tender? And most patients that get to the breast clinic actually have chest wall pain. So if you're trying to assess that, what you do is you dig your hand up underneath the breast and you press in. And the patient will often say, oh, ouch, that's sore, that's uncomfortable. And then you can just keep your hand under the breast and squash the breast tissue between your hands, and the patient will say, no, that's okay. So then you're able to tell, so this patient has got chest wall pain, they haven't got breast pain arising from the breast. If patients have got small breasts, you can't get up underneath them, you can roll them on their side and you can press down the edge of their pectoral muscle and then separately squash the breast tissue, and again tell the difference between chest wall pain and breast pain. So the management of this is to explain what's going on, that that they've got sensitivity because of their cycle, that they've got wear and tear pain in the muscle, to try and avoid or try and identify and then avoid activity which provokes the pain. A supportive bra can be useful. Simple analgesia, aspirin, paracetamol, ibuprofen, topical non-steroidals, ibuprofen or diclofenac are worthwhile. And so very occasionally we use specific treatment for cyclical pain, usually tamoxifen. It's probably 5 years since I've prescribed that. And again, we would encourage breast screening attendance. So referral guidance currently suggests that if you have a premenopausal patient with pain alone, that they do not need to be seen in a breast clinic. The current referral guidance says that if you have a postmenopausal patient who has had persisting unilateral pain for more than 3 months, that they can be referred. Now, that's actually the reason for that is that incidental breast cancer is obviously more common in older patients. The revised guidance says that if you've got a postmenopausal patient with pain alone, we don't need to see them, but we would encourage those patients to go along for breast screening when invited, because the pain is not likely to be because of anything untoward. They're likely to have chest wall pain. So moving on, breast issues in men. So we see a steady trickle of men in the breast clinic. The majority of them have gynecomastia. Gynecomastia, as you know, it's a common condition. It is often either unilateral or more marked on one side. So, if the patient comes in and said, "Oh, I've got a lump on this side," it may actually be breast tissue, but it's just a bit more marked on that side. Gynecomastia is due to ultimately to an imbalance in sex hormones. And it's therefore a systemic issue, and therefore we've got to have our kind of systemic head-on to think about where it may have, what the cause may be. So, and there's a stack of them, and some of them are here. So it's often physiological in puberty and in old age, as the testicles wake up and go back to sleep again. A lot of medical problems can do it. So liver problems, renal disease, testicular issues, including testicular tumors. Obesity can do it, because in obesity you make more peripheral estrogen, so obese men have higher estrogen levels. Previous cancer treatment can do it, usually because of damage to the testicles. A lot of drugs can do it, so alcohol, cannabis, opiates, and then a lot of drugs that we give patients, steroids, antiandrogens, digoxin, and a lot of common other medications. And again, the other one that patients take themselves are protein supplements. So folk who go to the gym a lot to take protein supplements, these are increasingly recognized as a cause. So running through those, if you see somebody with breast swelling. So, and if you're examining them, what you're looking for is, does this patient have just general swelling of the breast tissue, or have they got a discrete lump? And if they've got a discrete lump, then we need to see them. And it can be difficult sometimes to tell. A breast bud forming beneath the nipple can be quite difficult to tell. So if in doubt, we should probably see the patients. Other things to be looking for on examination are signs of liver disease, testicular lumps, testicular atrophy, and other systemic signs. we should be looking for the cause of gynecomastia from the history that we've taken, and we should be addressing any of those causes. If there is no obvious cause, then we can take blood tests, and there's a list of the ones that we would recommend there. And then if you find an abnormality in those, to address that. And if there isn't an obvious cause and the blood tests are all normal, then most of them will get better on their own. In terms of treatment, we will recommend for some or suggest for some patients trying tamoxifen. It's an unlicensed indication, and we know that some in primary care are twitchy about prescribing in those circumstances. So we will prescribe it in secondary care in those circumstances. Surgery, again, rarely used, and we wouldn't be suggesting surgery in a patient where there is an obvious predisposing cause, because it will tend to recur. Surgery is through referral, through the exceptional referral pathway these days, usually through plastics. Other issues in men, so lipomas are a not uncommon cause of lumps on the chest wall in men. So if you find a lump that's away from the breast tissue and it's soft and it's well defined, and it's superficial, and particularly if they've got other lipomas elsewhere, you can be fairly confident that that's what it is. Obviously, if there is doubt, we will see patients. Men obviously get skin lesions across the chest wall, and men rarely do get breast cancer. So, which is again why we like to see folk with a lump in the breast tissue. Moving on to skin issues now. So eczema is obviously common, and the areola is commonly affected. Usually the nipple is spared. So if you see somebody who's got bilateral changes, has got eczema elsewhere, and the skin changes are affecting the areola but sparing the nipple, you're safe to treat that as eczema, and you're much better at treating eczema than we are in secondary care. The thing that folk are twitchy about is Paget's disease, which is due to pre-malignant cells from the milk duct spreading onto the surface of the nipple. And in that case, you get changes on the nipple itself. They can then spread onto the areola, but the nipple itself will be affected. It's pretty unusual. It can be sometimes difficult to tell, and if we are in doubt, we will biopsy it. But if you're in doubt, send us the patient. The other thing to be aware of is keratosis. So this is the skin on the surface of the nipple is quite thick. So sometimes you get these sort of crusty, flaky skin on the surface of the nipple, and that's just normal crusty skin. The other thing that sometimes it's accused of being is dried discharge, but you don't get dried discharge. It's just thickened skin, and again, you can refer patients, reassure patients about that, and perhaps suggest a moisturizer if they want something. The other common nipple issue is nipple inversion, and most nipple inversion is entirely innocent. So the milk ducts running into the back of the nipple are a bit elastic, and they will sometimes pull in the nipple, and you tend to get this horizontal slit-like appearance. Often the patients will say, oh, it's not there all the time, the nipple will come out again, and that again is characteristics of benign nipple inversion. The patient can be reassured, and we don't need to see them. So malignant nipple inversion it's really skin dimpling, where there's a cancer tugging on the skin and the milk ducts, that happens to be under the nipple, so it pulls the nipple in. And therefore, because there's a cancer there, it doesn't come and go, because the cancer is there all the time. So and you don't get that kind of horizontal folded in appearance. with that. So if you see that, then we do want to see the patient. Nipple discharge again is common, and again is usually innocent. So if discharge is coming from multiple ducts or is coming bilaterally, if there's no sign of any blood in it and it's not troublesome, then the patient can be reassured. Discharge can be a variety of colors. It can be yellow or white, but it can also be green and black, and that does scare folks, but it's quite normal and nothing to worry about. Discharge that we're more concerned about is coming from a single duct. It's often blood-stained either to see or on dipstick testing. So just a urine dipstick you can put on the blood square to see if there is blood staining there. And it usually comes quite easily. You don't need to poke and prod too much to get that sort of discharge. So if you see that sort of discharge, we do want to see the patient, although still the vast majority of the patients, the underlying cause will be innocent. So as I say, the concern is with spontaneous single duct blood-stained discharge, particularly in older patients, and that the likely causes of that are an intraduct papilloma, so a little wart inside the milk duct. These can occasionally, maybe 5–10% of the time, be associated with DCIS. DCIS and cancer themselves can cause, less commonly, but can cause discharge. Ductectasia sometimes causes blood-stained discharge as well, but often there will be sort of multiple duct, sort of cheesy discharge. Physiological discharge, again, bilateral, a variety of colours, and often comes when provoked. Galactorrhea is copious milky discharge, and that's usually a systemic cause. So galactorrhea is specifically when somebody is not breastfeeding. So we're looking for things like drugs and pituitary tumours in those circumstances. So it's that's a systemic issue rather than a breast issue. Moving on to other skin issues. So skin cysts, as I say, are common. So due to trapped skin cells under the skin, you get this characteristic superficial lump often with a punctum that you can see. And in those circumstances, you can reassure the patient. They tend to be more common in folk who smoke or folk who are overweight, so encourage folk to lose weight and stop smoking, although we appreciate that is not necessarily easy. There is, you should be familiar with as well, the syndrome of multiple skin cysts, particularly under the breasts, in the axillae and in the groins, due to hidradenitis suppurativa. And again, we wouldn't usually intervene in these patients, apart from draining acute lesions if necessary. Again, with this condition, it's about losing weight, stopping smoking. Some patients taking long-term antibiotics for it, but we wouldn't usually intervene from a surgical point of view if we can avoid it. If the skin cyst's infected, a course of antibiotics, something like Coamoxiclav, will usually settle it down. If there's an acute abscess, then we can drain that. It may not, in your area, it may not be the breast team, it may be the general team that deal with that. If folk have got recurrent or troublesome lesions, we will sometimes excise these under local anaesthetic. Again, the team dealing with that may vary in your area. So again, if you've got a patient with a skin cyst and you're happy it's a skin cyst, we don't need to see them. But if the patient wants it removed, let us know that in your referral. And again, the patient is swapping a cyst for a scar, so that we may put them off. We may put them off that. depending on what bother it's giving them. Abscesses we may need to see. So the ones we tend to want to see in the breast service are lactating abscesses. Again, different areas that particularly out of hours that may have different arrangements for seeing these patients. The most common infective agent in lactating abscesses is flucloxacillin, so start them on that, and then get them to see the breast team by the appropriate local route. Periductal mastitis is another common cause. So this is where patients get inflammation and abscesses deep to the edge of the areolar margin. It's in smokers in the vast majority of cases, and these things can rumble on for ages. So we usually do want to see them to check up on them and to but there's less urgency about that. You usually go for coamoxiclav because anaerobes are often involved, and then occasionally we'll operate on some of these patients, but they will often burn out by themselves, so that can take months and months. Hidradenitis, as I've said, a broad spectrum antibiotic, and this is a skin problem, not a breast problem. We're not going to intervene. Particularly sebaceous cysts, as we've said already. So red areas, the thing that we're worried about in these circumstances is an inflammatory cancer. Inflammatory cancers present with edema and redness over the affected breast, because we think the lymphatic channels in that breast have been blocked by malignant cells. And people are anxious about missing it. It's actually usually fairly obvious, but if you are in doubt, we need to see the patient. There is a subset of patients who are referred who get patchy red changes, particularly over the kind of upper chest area, and that's because this is an area with lots of superficial capillaries. So if the patient blushes, that area may be affected as well. And if it comes and goes in those sort of circumstances, patients can be reassured. Other patients do get skin cancers, also things like seborrheic keratoses and things across the breast. If you're confident the diagnosis, that they can be referred through the dermatology pathway for malignancies. Skin metastases from breast cancer are actually relatively unusual unless it's a neglected cancer or in recurrence, and in those circumstances they present with small pink firm nodules, and there's often lots of them there, but pretty unusual to see that presenting as a primary presentation. Skin dimpling, so this is where there's a localized area where you can see a dent in the breast. It can be difficult to assess, particularly if the patient's had surgery, because we then distort the breast tissues underneath. We've often given the patients radiotherapy and things as well, so it can be difficult to tell. So if there is doubt, we would see the patient, because this is a concerning sign. The other causes are things like fat necrosis, so from trauma can cause skin dimpling sometimes. You can also see linear dimpling, where you feel, and you can actually often feel a kind of thread-like superficial line under the skin, probably due to a thrombosed peripheral vessel. It is benign, but if you do see skin dimpling, we probably need to see the patient to check it out. Similarly, edema of the breast, again, we would probably want to check out. Again, in patients who've had cancer treatment, it's not unusual as a consequence of a cancer treatment. Out with somebody who's been treated previously, sometimes you can get it with dependent edema, so a patient who's not mobile, lying in bed, lying on their side, on one side, with who will often collect edema on that side. But again, if there is doubt, we would want to check that out. Moving on to the armpit. So we've tried to integrate with the hematologist, because a lot of what we're looking at in armpits is lymph nodes. It's relatively unusual for breast cancers to present with isolated lymph nodes, but we do see it. But often what we're assessing is nodes. And again, in your area, the referral pathways for nodes may vary. Obviously, we see women. We tend not to see men with nodes in the armpit. So the hematology guidance suggests referral for axillary lymph nodes that are more than 2 centimeters, persisting for 6 weeks, or that are increasing, and also suggests looking out for other causes. So skin issues such as eczema in the draining area, connective tissue diseases such as rheumatoid arthritis, and new HIV infection as well, things to bear in mind. But if there is a node there that is persisting, we will see that and assess it, and biopsy it if necessary. If it is due to lymphoma, we will then refer on to the hematology team. Skin cysts in the axilla are very common. So again, it's one of these areas where we do see skin cysts and hidradenitis. Again, just manages skin cysts elsewhere. The other thing that we see is accessory breast tissue. So we all have a bit of breast tissue in the armpit. And the amount that we have varies, and it can vary from one side to the other. And the patients will describe that they'll put their arm up in the air and say, look, there's this bulge there. But if you feel it, there's actually not much to feel. It's all soft. There's not a firm lump as you would feel with a lymph node. And it often grows in pregnancy. So as patient's breast tissue develops preparing for lactation, that the breast tissue in the armpit will also swell as well. So you often do see it in pregnancy. So in these circumstances, the patient can be reassured. Some patients find it unsightly. It bulges over clothes and so on. We try to discourage surgical management of it, partly because it's cosmetic surgery and we've got enough surgery on our plate as it is, but partly because the wounds tend not to heal very well in the axilla, and you swap the bulge for a scar, which can be sensitive. Sometimes patients will feel normal tendons, normal structures in the axilla. So you compare it with the other side, and you can often reassure patients in those circumstances. And again, as we said earlier, pain in the axilla, because the chest wall muscles are running towards the arm, the patients will often feel pain there, but it's not necessarily because there's an armpit problem. It's because of the chest wall wear and tear. Breast implants are another thing we have to deal with on a regular basis. So the general principle with that is if there's concern that there's an underlying breast or an overlying breast lesion, then that should come to the breast service. If the concern is with the implant, then that can go back to the service who put the implant in. So if we've done a breast reconstruction with an implant, then we would want to see them back. But if it was done by plastics or it's cosmetic, it would go back to plastics. Other things that go to plastics, so congenital breast asymmetry, or patients wanting breast reduction surgery, that goes to plastics. Breast augmentation, again, you'd be hard pressed to get that on the NHS these days, but if somebody's really not developed breast tissue at all, they could be referred to plastics for that. So in conclusion then, use the guidance that's there on it's there on the Right Decision service. Use the cancer referral guidance, and the information that we've presented tonight. That's all on there. Tell us what you think. Do you think this is a lump? Do you think it's a skin cyst? Do you think it's a breast cyst? That you try to define cysts if you are sending a patient to us. And as I say, beware finding a lump if the patient hasn't noticed anything and presents with another issue. It's unlikely they've had a lump, because they will usually find a lump before you or I will. And I think that's all I have to say. I know it looks like Juliette's been typing in some advice as we went along there. But again, if there's questions that people have, I'd be delighted to answer those.
Thanks, Matthew. I was adding my little bits of practical advice about what goes to plastics and the waiting times and things like that. But does anyone have any questions? You've stunned everyone into silence, Matthew, at the end of the day with your comprehensive chat through.
And again, I don't know if there are any questions in the chat as well, or is it's mostly Juliette that's been.
It was just comments further up, I think. Yeah, we were talking about. There was one of the local breast surgeons, I'm not sure where Ken Ferguson's based, had said that ENPs and GPs are poor at examination. That's not my experience at all. I find that if there's pathology there, if there's a cancer or a fibroadenoma or a cyst, GPs, ENPs, patients, ourselves are usually very good at finding it. I think when it becomes hard is when to say there's definitely no pathology. If a patient can feel a lump, but you're not sure, I often find patients are more accurate than us, because breasts are lumpy in general. And the most useful thing that the ENPs that come regularly to our clinics find is that, like, getting used to what the variations of normal feel like is probably the most helpful thing. I rely a lot on asymmetry. So if something feels a bit lumpy on one side, but it feels very similar on the other side, that's quite reassuring. Whereas if it feels asymmetrical, that worries me a bit there.
No, you're absolutely right, and I think it's about, and it's relatively easier for us. You know, we're examining 20 new patients a week with breast issues. We've got imaging backup if we need it, and as you say, it's about knowing what is normal. Sometimes can be difficult, and we appreciate that those in primary care are dealing with all comers, and they may not be seeing that many people with breast issues. But so it is about trying in primary care, trying to upskill as best you can, and be aware of the guidance.
I think the main thing from us is, pain is not a symptom of breast cancer, so you can be very reassuring of pain alone. But if a patient feels a lump, even if it's quite subtle, we've all been caught up by something that a patient's adamant is a lump. You can't feel anything that's convincing, and they're absolutely right. It is a wee cancer. So patients are very good at feeling what's normal for them. So I think if a patient thinks they're a lump, they need to come to us, and that's why we went with direct access in Forth Valley, which has gone very well. We felt like if a patient thinks there's a lump, they need to come and be triple assessed. Lobular cancers and things like that can be very subtle at times. So it's better for them to come and to be assessed. And if they don't need to take 2 half days off work to go to the breast clinic and then to come in, that's helpful. Brian's come in saying comprehensive overview. Thanks, Matthew. And that the local breast services in Fife are excellent and very accessible. I think some of the feedback that you gave earlier about the variability, in some boards, referring routinely can mean, like in Lothian and Forth Valley, you're still going to be seen within 7 to 10 days, whereas in other boards, referring routinely can mean 8 or 9 months, and that's a very big difference if there's a possibility of cancer. So I think that's why we see different trends. Ben, I can see your hand up.
Yes, can you hear me?
We can, yes.
Yeah, fantastic. First of all, thank you very much, Matthew, for your great presentation. It was much appreciated. I just want to comment from you really about a little discussion that we had in Fort Valley about breast pain, which is obviously your strength in your field. So basically, we're doing a telephone clinic because obviously, as we said, breast pain does not need to have imaging if breast pain alone. And you also said during your presentation that postmenopausal ladies shouldn't need breast imaging with breast pain alone. Now, how does this tie in with the recommendation of the Royal College of Radiologists, which says that ladies over 40 should get an opportunistic mammogram? So I'll give you the practical example. We do see ladies in breast telephone calls, and we don't offer obviously any imaging. But then we see the same lady in clinic, and we tend to do an opportunistic mammogram. So possibly presenting with the same problem. So how does it tie up? Same problem,
so what the
approach.
RCR guidance says with regard to pain is that imaging may be considered. So what the folk who developed the breast pain guidance did was consider it. And the evidence is that the risk of an incidental breast cancer is 4 per 1,000. And that half the rate in breast screening is really not worthwhile. We've again the guidance that the RCR have given. We've commented on that, and we have suggested they may consider reviewing that at the next time that they do it. Obviously, as you get older, the incidence of breast cancer increases.
Mm-hmm.
So that is why we encourage those who have breast pain. We're not seeing them, but we would encourage those in primary care to encourage that patient to attend for breast screening in any circumstances. That way, any incidental cancers will be picked up. There's no evidence that you need more frequent, that having pain justifies more frequent mammograms there. So that I hope it explains that. I think the guidance, the new referral guidance, that we don't need to see those over 50 is due out probably early in the new year. That's in the process of being changed.
Well, that would be a great add-on. As you mentioned, it says it may be required, but that's a lot as a gap that obviously exposes professionals to backfire from the other side. Because as much as we can be confident in what we feel and what we think, on the other side, we've got a patient that may argue that wording. So obviously, I was just wondering about your comment about that.
I think, Ben, having these guidelines from, that we've got a Scottish consensus of how we should manage these, means that if we are reassuring people with pain alone that that's not a symptom of cancer and not imaging them, we're all very supported by having these national consensus guidelines that suggest that would be the right thing to do. And what it means is that we can free up between 1/4 and 1/3 of the appointments in the symptomatic breast clinic, which means that those patients that do have cancer can be seen and start treatment considerably faster.
Yeah. The other thing, now that you said freeing up time, obviously in your presentation, Matthew, you mentioned that if the problem is solved, we shouldn't see. Well, I don't think there's any way to stop the patient to come in and free up that slot.
I guess the issue is that, I not infrequently see patients who say, I went to my GP, I had a lumpy bit, and they referred me in, and now I think it's gone. And I contacted the practice, and they said just to go anyway. Now, my feeling is, if a patient gets to me and they tell me that their breast is back to normal, and I examine them and they're normal, I will not do anything else. So, I think that's the logic. That's why I say that.
Thank you.
Fantastic. Thank you so much, Matthew, and for doing that. I'm going to hand over now to yourself, Anne. Are you going to present your own slides?
I am, yes.
You are, perfect.
Thank
Fantastic.
you very much. Thank you, Juliet. And really nice to be with you here this evening and to share with you how the Right Decision Service can help you in accessing and using the national pathways from the CFSD to support your point of care clinical decisions. The driving force behind the Right Decision Service is the gap that probably all of us are aware of between evidence and practice. There's no shortage of information, evidence, guidance and pathways out there, but actually getting them implemented in routine practice can be very challenging, as you can see from some of the data here. 17 years potentially for good quality validated research to reach practice, for example. There is a whole suite of approaches called knowledge mobilization approaches that can really speed up the implementation of evidence in practice and help to make it more widespread. One fairly effective approach is continuing education meetings such as today's. But what we're going to focus on in today's session is decision support, where there is some really robust evidence from systematic reviews that decision support can really make a difference in getting evidence and guidance into routine day-to-day practice. We use a broad definition of decision support, as you can see over here on the right. Decision support tools combine good quality evidence and guidance with information about the individual person's needs to deliver reliable recommendations for action at key points in your day-to-day working processes. It's because of the known evidence that decision support can really make a difference in achieving evidence-based practice and making it a reality that Scottish Government has invested in a national decision support service for Scotland. That is the Right Decision Service. So the Right Decision Service, it has a mandate from the Digital Health and Care Delivery Plan, the Data Strategy for Scotland's Health and Care, and it's cited at many points within the Value-Based Health and Care Strategy or Vision and Action Plan. So it has a strong policy drive behind it. This is our kind of purpose statement, to be a Once for Scotland platform, so accessible as a kind of one-stop shop for everybody across health and social care, providing these digital tools that put evidence into practitioners' hands and citizens' hands as well in some cases through everyday technology, often web and mobile apps, but also in some cases embedding in electronic care systems. Over on the right, you can see the interface to the web version of the Right Decision Service and also the downloadable mobile app, which you can download from the app stores. Also, just to make people aware, particularly the primary care audience, we have a number of our decision support prompts and alerts specifically for high-risk prescribing based on the National Polypharmacy Guidance, now embedded in Vision and in EMIS electronic health record systems. That's been rolled out fully across NHS Tayside, embarking on rollout across NHS Lothian and looking to extend more widely. So these are alerts that proactively push prompts about safety of prescribing, where an individual patient record shows there may be a risk concern, and also highlights the appropriate recommendations for action. However, for today's purpose at present, we're going to really focus on the web and mobile access to the CFSD national pathways, and particularly the breast pathways. You can use the Right Decision Service to access, there's now 225 decision support toolkits published on our platform, many from national sources such as CFSD, others from local health boards that are delivering guidelines, pathways, risk assessment tools through the Right Decision Service. And that takes me on to the second way that you can use the Right Decision Service. You can approach the Right Decision Service team based in Healthcare Improvement Scotland and get our support in building your own web or mobile app that can be accessed through the Right Decision Service to help your organisation or your service to get evidence into practice in your work. We now have many organisations using the Right Decision Service in these ways. As you can see from the data here, actually all the territorial boards are using the Right Decision Service for at least some of their guidelines and pathways. Some are using it really as their primary source of delivering content. And with regard to national boards, 6 national boards are using the Right Decision Service to deliver national decision support tools, and that includes the Centre for Sustainable Delivery within the National Waiting Time Centre. So good traction and constantly growing, which has been great to see over the past few years. A few examples of what you can access through the Right Decision Service. I mentioned national guidelines. SIGN is now delivering all of its guidelines in a decision-ready format, not just long narrative PDF or web pages through the RDS. We also have the national prescribing guidance for diabetes, respiratory, polypharmacy, as I mentioned, all delivered both as web apps and as downloadable mobile apps through the Right Decision Service. And this is the palliative care guidelines, which I'm sure many of you are aware of, again delivered both via the web and as downloadable mobile app for offline use through the RDS. With regard to referral management pathways, a growing number of local boards are using the Right Decision Service to deliver their referral management pathways. This is one of the best established from Dumfries and Galloway. But of course, today we're going to focus mainly on national pathways being delivered by the Centre for Sustainable Delivery. I'll just show you here a bit more in-depth information about the Centre for Sustainable Delivery collection of toolkits on the Right Decision Service. You can see we have the breast pathways, dermatology, neurology, including the headache pathways, vascular surgery, and the cancer referral pathways will be added during the course of next year. Over on the right, you can see the downloadable mobile versions of these pathways if you are using them in a setting that doesn't have good internet access. We'll focus in now on the breast pathways. So you can see here, if you go into the breast pathway toolkit, you can access all of the pathways that Matthew highlighted in his presentation. And again, these are available both via the web and through the downloadable mobile app. Just to open up the first one, gynecomastia, here you can see the pathway itself is available in a, hopefully you'll agree, very nice, concise, easy to use format. The user can quickly jump into any one particular section that's of interest to them. There's also a little video at the top explaining a bit more about the nature of the condition and treatment. Exactly the same information published automatically to the mobile app as well. And clicking into one section, the pathway recommendations for management in primary care, you can see these are set out very clearly and with concisely and with a strong focus on specific calls to action. So intended for practical use in the day-to-day clinical setting, obviously underpinned by evidence. You can see we have the references there, but not intended as a detailed exposition of all that evidence. We use digital first design principles as much as possible to make it quick and easy for clinicians to get straight to the critical decision points and recommendations for action. So there's more we could do here with our design, but hopefully you can see some of these principles reflected: the use of white space, single point of access that everybody can get to know, segmenting up and organising the information for a quick jumping in to the appropriate point. I also want to highlight that in addition to making all these pathways available through that collection from the Centre for Sustainable Delivery, the way we've built the Right Decision Service enables local health boards to embed these pathways within their local referral guidance toolkits. So this is something that a couple of boards have now done, Dumfries and Galloway, and NHS Borders, which is just in the process of building its referral management toolkit. Going into the NHS Borders referral management toolkit, you will see that they have a whole variety of conditions covered with their, or intended to be covered with their local referral guidance, but they've been able very quickly to populate the breast pathways one because they've simply been able to automatically embed the 4 pathways that were highlighted from the Centre for Sustainable Delivery. And the same can be done with headache, dermatology, vascular surgery, and the cancer pathways when they appear. So hopefully you can see that ability to embed the national pathways within a local toolkit that contains local referral guidance, and to augment that national information with any local service information that's specific to the local area, really should help with improving that consistency in practice across NHS boards. A great benefit of this approach is that when the national pathways are updated, the same content is automatically updated in the local toolkits as well. And just a little snapshot of a survey that was carried out earlier this year around the Dumfries and Galloway referral management app. A very positive response indeed about how useful that particular app is, and many examples of changing decision making, including in dermatology and migraine management, where of course there are the national CFSD pathways. I hope that wasn't too much information to take in. Hopefully it's given you a bit of a taster of what the Right Decision Service can offer. Here's the links and the QR code for accessing the Right Decision Service on the web and through the app stores. And very happy for people to contact me or the team to find out more. If we've time left for questions and discussions, it would be lovely to hear your comments and feedback, including if you might be interested in this idea of a local referral web and mobile app for your board, where national pathways could be embedded. Thanks very much, Juliet.
Thank you so much, Anne, for that. That was fantastic. And Brian said, well done. Your perseverance in this field over decades is now paying off. I'm totally with him there. We've been trying to do this for a long time. And the platform, the app just now is absolutely brilliant. It's a fantastic resource. But I guess, like everything, it's as good as we make it, isn't it, in terms of our engagement? I'm certainly happy to chat to the Forth Valley team about whether we can look at, we have a MARGE as our local referral guidelines, which we have here, but there's no reason that we couldn't have those accessible on the platform. But yeah, if anyone's got any questions for Anne. It was a fantastic run through of just what's available, but the resource will be as good as we all make it in terms of what we choose to put on and everything like that. Well, in the absence of any specific questions for Anne, then I think we'll wrap up tonight. I'm aware it's 6:15, so we finished just as planned. Thank you so much to everyone for coming. Thank you to Matthew and to Anne for sticking to time and for going through all of their session. I think the feedback has been excellent. There's some contacts there at the end, just in terms of our website, where we can see the webinar series. This is the first, as I said earlier, but we've got the next one planned for the 29th of January for the National Headache Pathway, other webinars in development, and we will gradually increase that resource in terms of what there is there. So I think Jeff has circulated a feedback form, which would be really good to get back. If anyone can be bothered to feed that in and send it back to us, it would be great for us to get some feedback just about how we can tell people about these sessions, how we can let people get the links to them so that we get that reach to what I think will hopefully become a fantastic resource over time. So thanks again to Matthew and Anne, and thank you to all of you for giving up your time at the end of a busy day at work. And we hope to see you at the next webinar that's planned for the end of January. Thank you very much, everyone. Cheers. Bye-bye.
Thanks, everyone. Bye-bye. Bye.